is Dr. Nina back for another TOVA Tuesday for Your Health Matters on our TOVA Health channel. I wanted to share with you that there are so many leading healthcare providers and leaders right here in the state of Delaware that you may not hear about in the news journal. Maybe you have. And I thought that Dr. Gill, who is a family practice doctor, needed to come on our show. The reason being is because he is championing making sure that all Delawareans have access to high quality care. And so I thought that some people don't know what high quality care looks like. And I said, today I have the perfect person to answer these questions. Remember to follow us on Facebook at #TOVA Community Health or on our Instagram page at TOVA Community Health #. You can also find out any more of Your Health Matters videos at www.tovacommunityhealth.org. So today I want to introduce you to Dr. James Gill. He is the co-owner of Family Medicine at Green Hill. Welcome to the show today, Dr. Gill. How are you?
Good. Thanks, Dr. Anderson. Really appreciate your having me on.
It's been really important, and part of my journey too is I've learned so much from you and your passion really for serving the community. I consider you a community doctor as well, who's worked in Delaware and has a lot of relationships and very long-lasting relationships with your clients and your families. But I wanted to ask you, because I did look up and found out that you did your bachelor's in psychology at Rutgers.
Actually, my bachelor's was at Boston College. My medical school was at Rutgers.
So you went from trying to understand human behavior to becoming a doctor. How did that happen? Tell us about your background.
Sure. Yeah. Well, I come from, I grew up in New Jersey, and my parents and other people in my family had not gone to college. My father worked in a grocery store, but of course, one of those situations where my mom really wanted me to be a doctor. Mm-hmm. And so when I initially went to college, I thought maybe that would be the track that I would go on.
Become a psychiatrist?
No, not really. I think I didn't really know. I didn't actually have any role models who were in healthcare, physicians or others. And so I didn't really know. It was just one of those things that people would say, oh, you do well in school, you should become a doctor. That's a good thing to be. I really didn't know much about it. So in college, I started on the track of taking sciences, which, many people who want to go to medical school do. And I really wasn't that interested. I got much more interested in social justice issues. And I was actually going to change my major to philosophy and theology, but that was a little too radical for my parents. So that's how I compromised on psychology. That wasn't quite as radical, but I kind of decided in college, I thought I really did not want to be a physician. Again, I didn't really have good role models, but the ones that I saw, I was in Boston, and a lot of what I saw were people who did very high-tech medicine, not really, developing relationships with people over time. I just didn't have experience with them. So I didn't think that's what I wanted to do. So I thought in college, maybe what I really wanted to do was to do some social service work. Maybe I kind of thought maybe I would run a soup kitchen. And so I decided not to go to medical school, and instead I went into a volunteer program, kind of similar to what's currently AmeriCorps. It was a Catholic organization, and I worked with delinquent teenagers. Well, they called them emotionally disturbed teenagers, but after having kids and being a teenager myself, I think
they're probably normal.
They're probably normal, right? That's kind of redundant to say emotionally disturbed teenager. No, just kidding. And what it turned out was actually the person who's currently my wife was the nurse for the same population. She went into she had done nursing for a few years, and then also volunteered for the same organization and worked with these kids who were trying to work with troubled teens. I was the youth minister. I was not very good at it. And she was the nurse. She was very good at it. And I said to myself, well, maybe you can.
Nurses.
Yeah, I said, maybe you can do healthcare and actually make a difference in the world. And so it was there that I decided, okay, I think I will consider going to medical school. So I applied to the state medical school in the state I was from in New Jersey. And that's where I ended up going. But always with a vision towards, if I'm going to be a physician, it's really to develop long-term relationships with people and to really help populations who might have some disadvantage. That was really my goal. So that's really why it was natural to go into family medicine, primary care in general, but family medicine more particular. I was really not interested in sort of the more technical parts of medicine.
Mm-hmm. And I would also say that you were also a ice cream scooper at Richmond's Ice Cream that closed down in New Jersey, which a place that I loved when my parents took us to the beach.
Wow, how did you find that? How'd you find that? Yeah.
You told me.
Wow, that's you're pretty good. Yeah, well, when I was a teenager, my father's second job, because again, his first job his main job didn't make a lot of money working at the grocery store. So he had a second job where he was an assistant manager at an ice cream place called Richmond's. And so one of the advantages of that was that myself and my sisters could get jobs as teenagers, and they were waitresses, and I was an ice cream scooper. And so yeah, we scooped a lot of ice cream, but it was a wonderful experience. I mean, I think all kids should have jobs so that they have some understanding of what it is to have to work to buy whatever you need. But I've made lots of friends, many long-lasting friends doing that. So yeah, that was fantastic.
And the ice cream was good there. I love it.
That's true. That's true.
So tell me, you decided to go into family practice, and I know a lot of residents and ones I talk to, they want to become specialists because they want to make lots of money. Why did you choose primary care and family medicine as your track?
Yeah, well, that really came from how I got interested in medicine. And it wasn't that I was interested in medicine and then I was just going to decide, oh, what specialty do I want to be? I really went into it thinking the purpose of going into medicine was to work with, to help the world in general. Sounds a little too, a little, that doesn't have a lot of meaning, but to really develop long-term relationships with people and to have some impact on people's lives. So again, that's a little hard you can have an impact on people's lives no matter what specialty you're in. I don't want to diss other people's specialties, but I think it's a little easier if you develop long-term relationships with people and you can, I'm a real fan of taking care of whole families. I think that people's health is really formed in childhood and infancy. And so I think it's best if children are taken care of by the same practitioners that are taking care of the parents, and that's what family medicine is all about, taking care of them long term, from the time that they're born until maybe the time that they die, if you have that much time to have a relationship with them, and also to have an impact on their communities, and to do some things that can help communities, because we know that healthcare is not really good. Health is not really driven mainly by healthcare. It's really driven by what now would be called social determinants of health. So to what extent you can have an impact on communities and try to have a positive impact on health disparities, but really just social disparities in general. So that's why really get involved. I get involved through my church and through other organizations. I think that's also where you have an impact, and I think even more so than in healthcare. But the two things are very linked. So I think getting back to why family medicine, I think it's a much more natural link to be a family physician, to be having relationships with people over time, to have an impact with their lives over time, is much easier as a family physician to also have an impact on the communities that they live in as well. So that's why I think family medicine for me.
Awesome. And I also want to say that it's been a pleasure working with you, and I've learned so much, and how you have just provides just high quality of care to your clients. And although I want to say that they sometimes get upset when they say, "Oh goodness, I haven't been in to see Dr. Gill in a while. He's going to kill me." I said, "You know what? But he cares, so don't take it personal."
Yeah.
So I also wanted to talk to you that although we both value primary care in an environment where, people think if you go to the hospitals a lot, you see a lot of specialists. If you have a lot of tests, that means you're getting better care. But in Delaware, between 2018 and 2019, lost about 11 primary care practices. Is that correct? And what are your concerns about that?
Yeah. So actually, I didn't actually know the exact number, but that sounds about right. And for years, really decades, there's been a problem with loss of primary care throughout the country, but Delaware is worse. And the reason that is kind of what you alluded to earlier, that certainly you can make a lot more money for a lot less work being a specialist, particularly a specialist that does a lot of procedures. And the reason is that in the United States, the priorities in healthcare are really turned upside down. In most of the rest of the world, people understand that good healthcare is driven by good primary care. And so most of the rest of the world has primary care as the foundation of their healthcare system. So a large proportion of their resources are put into primary care, and they put resources into specialty care as well, but they understand that if you don't have good primary care, specialty care is of little value. In the United States, it's the opposite. We put most of our resources into specialty care, into high-tech care. That's not necessarily good. Specialty and high-tech care is not a bad thing, but if it's not driven and coordinated by good primary care, it actually doesn't improve healthcare very much at all. So, and this is known, this is understood through research throughout the world and throughout the country, that the more you have good primary care, the better health is for the population. The more you have specialty care that's not coordinated by primary care, actually the worse your health is. It's more costly, but healthcare is worse. If you have good primary care, your healthcare is better, and it's actually less costly. So this is known throughout the world. The problem is it hasn't really been recognized in the United States until very recently. There is a move now to try to turn things around. Delaware is really behind. The United States is behind the rest of the world, and Delaware is behind the rest of the United States. Delaware is the worst state in the country in terms of how healthcare is delivered. We have one of the poorest primary care systems, and we have one of the most expensive specialty and hospital systems in the country. We are trying to change that, but it's very slow. So unfortunately, what's happened is that people, I'm sure like myself, who went into primary care not to make a lot of money, because you can certainly make much more money for much less work being a specialist. So they went into primary care because they had a passion for it. But you can only do that to some extent. If you can't, you still have to run a business. Your practice is still a business. So if you're losing money every year and every day, and you can't pay your staff, eventually you can't do it anymore. So as the payers in Delaware have paid less and less to primary care, much worse and much less than anywhere else in the country, practices have started to say, I can't do it anymore. I have to either retire early, just get out of care in general, or leave Delaware and go to a state where things are a little bit better, or maybe I'll sell my practice to a hospital. And people might say, well, what's the problem with that? Well, the problem is when you sell your practice to a hospital, costs to the healthcare system go up by 50 to 80%, but healthcare quality and access does not go up. Access actually goes down when doctors sell or give because hospitals don't pay for practices. So when when practices just give their practices to a hospital, costs go way up, access does not. So it's unfortunate.
And I would say too, that's not a sustainable path when you're talking about economics and the uncertainty of the climate here, that you cannot spend about 25% of your state's budget just on Medicaid or healthcare costs. At some point that's not going to be a sustainable path for a government to operate. Would you say that?
Yeah, that's absolutely true. Again, our health, I remember when I was doing my master's in public health, and they were talking about how the percentage of total economic what's called GDP went into healthcare, and it was about 10 to 11%, and people said, "Oh, this isn't sustainable," and now it's above 18%. So it just continued to go up, 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 up. So no, it's not sustainable. And so what needs to be done, and it is happening in the country to some extent. Delaware is a little slower. What needs to happen is that more resources need to get put into primary care, and we need to stop paying exorbitant amounts for hospital and high-tech care. In Delaware, often what's used as what does Medicare pay, and people use that as a marker. So in Delaware, prior to a law that we just passed, Delaware was paying, Delaware payers were paying about 30% less than what Medicare pays for primary care, but they were paying 2.5 or 3 times more than what Medicare pays for hospital care.
Wow.
That's completely unsustainable. The system is completely turned on its head. So what needs to be done is that, I'm not saying that primary care physicians should be getting paid so much more than specialists or hospitals, but the playing field just needs to be leveled. Everyone should get paid similar in terms relative to the work that they do. Hospitals shouldn't get paid 2 and 3 and 4 times as much relative to the work that they do as what primary care doctors do. So yeah, you're right. It's completely unsustainable. And if we stay on this path, healthcare costs will continue to go up, 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 and quality and access will continue to go down in Delaware and in the United States.
Wow. That's unfortunate, but we have ambient legislation to encourage payers to reimburse primary care better. So tell us about that. Tell us about that.
Yeah, so things were so bad that about 3 years ago, we started on an effort to embark on a legislative fix to improving care in Delaware. So we had tried to work with the payers over at least 10 years to try to get them to improve things just voluntarily without having to go through legislation. And they just would not, just completely refused. So we said, well, look, what has to happen is we have to do this legislatively. So I had just gotten on our state medical society's legislative committee, and I kind of led the process to say, well, let's try to do this legislatively. So I started working with some of our state legislators, one of whom actually used to be my student when he was a graduate student at the University of Delaware in economics, and I was doing research in healthcare access and quality, and he was actually my student. And by the time this happened with legislative, he had become a lawyer, and he had won a Senate seat, and he was the chair of the Senate Health Committee in Delaware. Wow. So I went to him. I also went to his name is Brian Townsend. Mm-hmm. I went to my local legislator, and we started talking about it, and they all agreed. They said, this is completely ridiculous. It's not good for Delaware. It's not good for Delawareans. It's ruining our healthcare system. It's making healthcare much more expensive, but much poorer access and quality, and let's try to fix it. So it was interesting because initially anyone who knew anything about legislation and politics said, well, it's a great idea. It's never going to happen right now. It'll probably take 3 to 5 years. That's the way most things happen. The first year you talk about it, people say it sounds like it might be a good idea. Maybe it'll get to committee. It probably not pass the committee. You bring it back next year. Maybe it passes committee, doesn't pass the legislation.
There'll be no primary care doctors left by then.
That's exactly what I said. I said to people, well, I understand how politics usually works, but we can't do that because exactly as you said, by the time it happens, there won't be any primary care to work with. And you can't just get it back. It just doesn't happen that way. And everybody said, well, we understand, but it just never happens that way. Well, it actually got passed that year unanimously. And what got passed is not a complete fix, but to say, look, we have to throw primary care a lifeline, so at least they don't continue to go out of business right now. And it was funny because the way we were passing the legislation, we said the payers in Delaware had to pay at least Medicare rates. And actually, we tried to get national organizations on board, and they said, we can't get on board with that. Medicare rates are just way too low because nowhere else in the country would do that because it was considered such poor reimbursement that they said, and we said, well, no. For us, that would be an improvement to get Medicare rates. So it was funny because, so I guess what I'm saying is that the legislation was just to give bottom of the barrel rates reimbursement to primary care, so they weren't continuing to go out of business. So that was the legislation. And then the second part of the legislation was to say, let's form a committee. They called it a collaborative to create a more long-term fix. So we'll give this we'll require this bottom of the barrel payment so that primary care doesn't at least continue to go out of business. And then in the meantime, we'll form a collaborative to do a long-term fix. And the collaborative will be formed of physicians and nurse practitioners and hospitals and payers and Medicaid and government people and employers, a wide variety of stakeholders to really come together. And that collaborative has been in existence for now about a year and a half to try to do a longer term fix. But it's been really difficult. The payers and the hospitals are really resistant to change because the hospitals understandably want to continue to get paid 2 or 3 times as much as what Medicare pays. I understand if you get paid a lot and you're making, the hospitals have, hundreds of millions of dollars in profits each year, and they don't want to give that up. And again, we don't want our hospitals to go away, that's for sure. We have good hospitals, but there's no reason for hospitals to be making hundreds of millions of dollars in profits while primary care is going out of business and people can't find primary care doctors. We have to just even it a little bit. So we think we're making a little bit of progress, but it is very difficult to get the hospitals and the payers on board. They're very resistant to change.
Yeah, and just the fact that you champion this is amazing that you were able to get it passed in such a short amount of time. I think it's a phenomenal feat.
Yeah, well, thanks. I keep trying to tell myself that it's still positive because 2 years later, I feel like we haven't made much additional progress. But hopefully we will. The chairs of the committee are excellent. Brian Townsend, who I worked with initially, and David Bentz, who's his counterpart chair in the House, and then Nancy Fan, who's the chair of the Healthcare Commission. They're the co-chairs, and they're completely on board. It's really trying to get the hospitals and the payers to agree to some even very small level of change. It's been difficult, but I think we can make progress, and we continue to try.
That's great. So I wanted to share with the audience that Dr. Gill is very passionate about his clients receiving high quality care, even in a primary care setting where primary care providers, we don't make a lot of money, but we want to make sure that our clients get access to better care. Can you talk about how you're able to do that?
Sure, yeah. So we've found some ways to continue to provide good access as our colleague practices are going out of business or leaving practice, leaving the state, or selling out to hospitals, or I should just say giving up their practices to hospitals. We've tried to continue to provide good access to care. One of the ways is we've tried to have a more team-based approach to care, where we have nurse practitioners, which lots of other practices do as well, to work with us, and nurses to work with patients who have chronic diseases, and to do what's called chronic care management. So we found ways that even though payment for primary care is very, very poor, there's little pockets, little areas where you can get paid to do things like chronic care management. So we found ways to do that, to pay enough to get nurses and nurse practitioners and others to help us with care. Yeah, we've expanded our access, so we're open much longer hours than most other practices. We're open on regular weekdays from 7 a.m. to 7 p.m. We're open on Saturdays to see patients. I still go to the hospital to see patients. I have a newborn in the hospital right now that I have to see after we finish. So we really try to do that. We do it through other mechanisms too. Another way to do it is through telemedicine. And telemedicine is a big thing now because with the COVID pandemic, people didn't want to come to offices. Some offices closed their practices to, they wouldn't see patients in the office anyway. We said we're not going to do that because we don't think that's a good idea. Much better to figure out how to keep well and sick patients, separate so that they don't infect each other. But other practices weren't doing it at all. But telemedicine is a good way to do it. We had already been doing it for about 3 years. And we understand a lot of people have difficult lives. They have difficulty with transportation. They can't get childcare. They can't get out of work to drive to the doctor's office and wait in the waiting room. So telemedicine is a way that they can do their visit in 20 to 30 minutes instead of having to take 2 or 3 hours out of work or get daycare for half a day. So all of these things are a way to improve care. Obviously, those things are even more difficult for more vulnerable populations, people who are lower income, who have jobs that don't allow them to take off. So I think it's particularly important for those populations. So we've been able to do it. It's been even more difficult through the COVID pandemic, but we've tried to continue to do it, and we've tried to use that as a model to help other practices to do it. As we're trying to get payment to increase to a level where you can really sustain for the long term, we're trying to help practices to figure out ways to do it like we have to at least keep it going for the short term.
And I think the practice has done a fantastic job, and the clients really appreciate the fact that we stayed open. We offer COVID screening to clients as well, and really tried to isolate the sick patients from the well visit patients as well.
Yeah.
So I wanted to just segue into another part of what high quality care is. Not to mean that you have to have a lot of expensive high-tech care. But I want to ask you this question. Do more tests, more labs, more referrals to specialists mean that I'm getting better care?
Right. So usually not, but particularly not if it's not coordinated with your primary care provider or clinician. So I think the biggest problem is if people go to specialists and emergency rooms and hospitals where they're not referred by their primary care provider or clinician. That is actually much, much worse. You will be sicker, you will get more unnecessary tests, that's really, really poor care. So tests are good, procedures are good, seeing specialists is good if it's referred by and coordinated by your primary care provider. So only if your primary care provider, you are seeing them first and they decide that you need this, then it's a good thing. If you just go on your own and you go to emergency room and get testing, that's a bad thing. If you go to a specialist not coordinated by your primary care physician, that's a bad thing. And study after study after study has shown that seeing a specialist not coordinated by your primary care actually leads to worse health. And it's understandable because the specialist doesn't know your total picture. So they're going to order tests that are maybe not necessary, not in the context of the rest of your health. And they don't know. It's not because they're a bad doctor. It's because that's not what they're supposed to do. They're specialists. They're not coordinating your overall health. They assume that if you're coming to them, it's because you're seeing your primary care provider and they're sending you to them. And so they're making that assumption. If you go without that, then you're doing yourself a disadvantage. So it's really important not to see a specialist, not to go to a hospital or emergency room unless you've seen your primary care provider first, and unless they specifically say that this is what you need to do.
Yeah, and I would just to say that we've also adopted that model even for our sickle cell clients to really provide very good, high quality primary specialty care. And I have just been amazed that we've been able to keep even the most complicated patients out of the emergency rooms and really provide very high quality coordinated care, which is, it's something I had to grow into because I, didn't have much experience into really developing a model of care to really meet their needs. But what I found is that the sickle cell patients of mine are really no different than any of some of the other complicated patients you have in the practice. So if you just set the bar high for everyone, it brings the access to care better for everyone.
Yeah, absolutely. Yeah, and that's sometimes hard for people to understand because I think Americans love high tech. They love bells and whistles on their cell phone. They love, apps on their cell phone or computer, and they think, oh, better tech, high tech is better. And the problem is in medicine, every test, every procedure, every medicine, every surgery can be helpful, but it can also be harmful.
Right.
So each thing you do has a much greater chance of harm if it's not done in coordination with your primary care. And that's hard for people to understand, but it's really true.
Yep. So I wanted to segue too to talk about it, something that I have done a lot of advocacy work in. As you know, sickle cell disproportionately affects people of African American descent here in this country. But what I've found along this journey of trying to provide care to our clients, especially during this pandemic, but African Americans are more likely to have underlying medical conditions such as diabetes, hypertension, and obesity, and are very unlikely and sometimes are less likely to have a primary care provider or be insured in this day and age. Why is this the concern to you as a primary care provider? I thought we had this issue already figured out.
Yeah. I wish we did. We definitely have not. So I think there's a couple of issues. The thing that's probably the most difficult to get at is there's clearly bias in the healthcare system against minorities in general and African Americans in particular. And I think we would have hoped that we would have gotten past that problem. I mean, haven't we been through this already through Reconstruction and civil rights in the 1960s, but we haven't. And in today's, environment, with what's going on with violence against African Americans in the police system and other places, we know that we have not solved this problem. And it's certainly true in healthcare as well. And, it's a little embarrassing to me as a white person to think, you try as best as you can to not have bias. But you have to understand that we do have internal biases that maybe we don't even understand. So that's one thing. I think there's biases in the healthcare system inherently, and we have to overcome that. So all other things being equal, even if African Americans were not more likely to have healthcare issues, they would still be at a disadvantage. And we have to do everything we can to train healthcare workers to try to overcome that as best as they can. The same as we need to train people who are we need to train police, honestly. So that's certainly one issue. But it's also true that African Americans are much more likely to have chronic health conditions than white people, or even other minorities such as Asians, for example. African Americans are much more likely to have underlying health issues than Asian. So it's not just a issue of being a minority in a population. There's, we know, and I don't think we completely understand why, but some of it might be social disparities or social determinants of health, but some of it is even in addition to that. So certainly African Americans are much more likely to have high blood pressure is one that people talk about all the time. That's certainly true, but also diabetes and other health disparities. But even worse, given that people have those health conditions, let's say diabetes, for example, let's say high blood pressure. So an African American and a white person with high blood pressure, the African American is much more likely to suffer negative consequences of their high blood pressure than the white person who also has high blood pressure. And again, you might say part of that probably is because of the biases in healthcare delivery, but part of it is probably this, that African Americans are more likely to suffer complications of high blood pressure than white people are. And so we need to be more attentive to, in healthcare, treating African Americans who have high blood pressure, because we know that they're more likely to develop complications. So it's a major problem. We need to give much more attention to it, and we need to put much more resources into it. Yes, we need to train our healthcare workforce, to try to overcome their implicit biases, which they're going to have, no matter how much training you have, but to try to overcome that. And then secondly, to understand that people of different ethnicities, and it's probably not just African Americans or other groups too. For example, we don't have a lot in our area in Delaware, but Native Americans also very much more likely to have both chronic health conditions and consequences. Diabetes is a big one for Native Americans. So it's not just African Americans. In our area, African Americans are probably the most affected. So we need to pay much more attention to treating people more aggressively, but also working with them much more collaboratively to try to avoid this. Another example is through COVID. I mean, I think through the COVID pandemic, we've seen that African Americans are much more likely to get COVID, but then once they have COVID, are much more likely to get hospitalized. And if they're hospitalized, are much more likely to die. We don't exactly know why right now, but it's clearly true. We're not talking about small amount. We're not talking about 10 or 20% more likely. We're talking about 2 or 3 or more times more likely. So we're talking about huge, huge disparities. And for COVID, we don't quite understand, the reasons why. But I think COVID really shone a light on the disparities that we know already exist with other chronic diseases. Well, COVID is not a chronic disease, but with chronic diseases such as high blood pressure. So getting at implicit biases in healthcare delivery, getting at social disparities and social determinants of health, and then being more aggressive when we treat each of the health conditions are probably 3 different ways that we can get at these issues and disparities. It's not easy.
Yeah, it's not easy, but I think, just a point that you said is that access to primary care, at least having a primary care provider, having a good relationship with your primary care provider is a step in the right direction. Absolutely.
Yeah. And I wish we had more African-American primary care healthcare providers. I mean, I think we're, African-Americans are underrepresented as healthcare providers in general, and that includes primary care. And I think it's, honestly, I'm a white person. I would hope that I could take care of African-Americans, as well.
You do a good job.
Well, thank you. But honestly, it's not good enough. So we need more African-Americans in healthcare, and as healthcare providers and as primary care providers. So that's probably a 4th way that we can work towards improving disparities. And just like, for example, I think, we can also learn, as healthcare providers, I'm working through our state medical society. in terms of what do we do as a state medical society to address the issue of violence against African Americans in our society. And so, we look at our group and we say, well, one problem is that, like 95% of us on this group are white guys,
Yeah, or on the board of directors, where are
exactly. But we say, fortunately, there's at least one black woman on the group.
Yeah.
There's at least one black man. We need more.
Yeah.
And let's look to them for leadership on the issue.
Yeah.
I think the same is in healthcare, honestly. It's like if we're going to fix these problems, we don't just want to say as a bunch of old white guys, how are we going to fix the problem? We want to say, let's ask our colleagues who are African American to really help us and to take the lead. And we need to do that, but we also need more of them to help us. So that's another issue.
I would agree with that 100%. But I just want to also say that even during this COVID-19 pandemic, although you had been offering the practice telemedicine visits for 3 years, it really didn't take off until COVID-19. And I would say that telemedicine has really soared over the last 2 to 3 months. What would you say your clients' experience with providing this care virtually has been? And I know we have had to adapt as well, but it seems like that there's been some good positive experiences that have come out of that.
Yeah, I think absolutely. So you're right. We have been offering telemedicine for about 3 years before COVID hit. And the patients who used it loved it. We encouraged patients to use it. Again, I think it helps people who have more difficulty with access, particularly because of issues like transportation, childcare, getting time off of work. It really helped. It was really helping. What actually interesting, I know I'm on the board of an organization called Catholic Charities, and one of the things that Catholic Charities does is to provide mental health counseling to a large population. And we had started to get telemedicine there. It was interesting because one of the things that the woman who directs the mental health services for Catholic Charities, we asked her for an update, and she said one of the interesting things is that not only is it good, most people would say, well, telemedicine is a good thing. It's always better to have an office visit, but telemedicine is good enough. And, it's great for people who don't have access. She said, actually, it's better than good enough. She said, for a large population of people with mental health problems, it's actually better than face-to-face. A lot of people with mental health problems, they have difficulty not just getting to the office, but sitting face-to-face in front of their healthcare provider because it's intimidating. It was really eye-opening to me.
Think about it like that.
Especially people who are on like the autism spectrum. But also people with severe depression, some people who are schizophrenic. She said they actually got better counseling via telemedicine. Amazing to me. So, but for most people, face-to-face is generally better, but but this helps in terms of access. So people loved it who used it, but until COVID, we might have 1 or 2 of those in a day because people generally preferred to come to the office. So out of about 60 or 70 visits in a day, 1 or 2 would be telemedicine. When COVID hit, so our visits went down a little bit because just of COVID, maybe went down to 50 or 60 visits in a day. Half of those would be telemedicine. So people did it because they felt like they needed to. They didn't want to leave their house. They didn't want to be exposed in a healthcare setting. So many, many, many more people were using it who never used it before, never thought about using it. If we suggested it to them, they said, no, I don't want to do that. I'll come to the office. I don't know how to do that on my phone. Now I'll just come to the office. And now they're kind of encouraged. They don't want to leave their home, so they've been encouraged to use it. And now they say, wow, this is great. I can talk to you about my diabetes or my high blood pressure without having to leave my home. Or maybe I don't have to instead of taking 3 or 4 hours off of work, I can take just 30 minutes off of work to do my telemedicine. And they say that's fantastic. And they love it. So what we're hoping is that people continue to use it. It probably won't be half of our visits, but it won't be 2%, which it was before. Hopefully it'll be somewhere in between. What we also need to do is to make sure that the insurance payers continue to pay for it. So during the COVID pandemic, some payers that were not paying for telemedicine at all, like Medicare, they said, okay, now we're going to pay for it because we don't want people coming to the office and getting COVID and getting hospitalized. So we'll pay for a telemedicine. There's a strong lobby to get Medicare to continue that, because there's absolutely no reason to not continue it. It's much better access, sometimes better care. And again, if Medicare backs off and says we're not going to pay for it anymore, it'll again make access much worse, and it'll make costs much greater. So hopefully the payers will continue to pay, because now patients love it, and many people are getting access who would have otherwise had a lot of difficulty.
Yeah, it's been amazing how we've been able to really provide high quality of care from home, and they're more comfortable in their own home setting. And also, they don't have to drive the transportation issues, and we're still able to serve them in most cases. But I would like to say that, over the last couple years, I've definitely seen that your work has championed legislation. I've seen that there's more and more attention to primary care. So I would say in Delaware that we have some ways to go, but as far as access to care, that has improved. But what would you say we need to go to next? What direction do we need to go now?
So we need to have the work that was started by this collaborative, or started by the bill that required increased payments to primary care in Delaware. It was SB 227, to continue, and for the collaborative that was formed by that legislation to actually have positive results. And again, we need to agree. I think right now the collaborative is trying to do things collaboratively, so they want everyone to agree. We might not be able to have the hospitals or the payers agree. The hospitals would like to continue the status quo. They would love to continue getting paid 2 or 3 times as much as everyone else for the same work. I think they understand that that's probably not going to continue. So what might have to happen is for basically Delaware as a population and as a society to just say, this is what we need to do, even if the hospitals don't really want to do it. So we hope we can have positive change through collaboration and through everyone agrees. But if we can't, we just need to say that this is what it needs to be done for society. So what needs to happen is that, so number one, so there's a general sense in the country that primary care needs to get about 12 to 14% of total healthcare resources in the country, of what gets paid for healthcare. Right now, it's about 6% throughout the country. It's about 4% in Delaware. So we have to double or triple the funding that goes into primary care. That's a given. So that has to happen. Once that happens, people will start to go into primary care again, and they will stop leaving primary care. Right now, hardly any students go into primary care. Why would you? I mean, even if you have a passion for it, why would you go into something where you work twice as hard for 1/2 or 1/3 the pay? Doesn't make any sense. Yeah. So we're going to have to make these changes. Once we make these changes, then we'll start to attract students again to go into primary care. It is happening across the country. Many other states have passed legislation. Rhode Island was the first one to do it. Then Oregon did it. Colorado did it. Connecticut did it. Many other states are doing it as we speak. So it's going to happen throughout the country. It needs to happen in Delaware. What we did already was just the tiniest change to try to stem the bleeding. We need to continue that to move towards, to double or triple the funding that goes into primary care, so that people can have access to their primary care provider, and that more primary care providers or more healthcare professionals go into primary care. And if that happens, which I think it will over the next year or two, I think we can be in really good shape. But we have to convince, I would like to convince the hospitals and the payers that they need to do this. If we can't convince them, then just as a society, we just have to say, we're just going to do it,
enough is enough.
whether you agree or not. Yeah, we can't continue to have a system that has poor access, poor quality, and extremely high costs just because the hospitals want to get paid, 2 or 3 or 4 times as much as they should.
Wow. And who are the senators that are sponsoring this bill?
Right. Well, it's not actually another bill right now. It's what the collaborative. So it's not actually a bill on the table right now.
No, it's not. Okay.
So the people who are really the leading people are, from a legislative point of view, are Senator Brian Townsend, who's the chair of the collaborative, who's the chair and also the chair of the Committee on Health in the Senate, and Representative David Bentz, who is the other co-chair of the collaborative and also the chair of the Health Committee in the House. So they're the leaders right now. We don't know if it's going to be done legislatively or through regulation. The Insurance Commissioner's Office was given the authority to create regulations. And so the Insurance Commissioner's Office is working with the collaborative to do that. And to mention the third person who's the collaborative co-chair is Nancy Phan. She's there because she's the chair of the Delaware Healthcare Commission. So those 3 people who are the co-chairs are leading things legislatively with the Insurance Commissioner's Office. And so things will get done if it doesn't get done through a collaborative mechanism, it'll get done through a regulatory mechanism. If it can't get done through a regulatory mechanism, then we will introduce new legislation.
Well, we definitely are in full support. And for the community, please stay abreast of this, because this is very important that we work with primary care providers and that you have access to high quality of care. So I thank you so much. I've learned so much from you from always. And thank you for coming on this show today, Your Health Matters. But I put this up because this is actually in my office. And I think it's really important that people know that more care is not always better care. And really, it's really important to have a good primary care provider to coordinate the care that you need, even if you have a lot of multiple chronic conditions, even like sickle cell, hypertension, diabetes, and others. But Dr. Gill, you've been in practice now for about 20 years, and working as a family practice doctor is very hard work and stressful. But what has been the most rewarding aspect of providing care in the community?
Yeah, so I think for sure it's it's developing relationships with patients and families over time. So I love having families that I take care of with parents and babies and children and grandparents. And then what I particularly love is then when those children grow up and they have their own children, and then I take care of their children as well as them and continue to take care of the families, the adults, and the children. That is extremely rewarding. And then it's also rewarding, it sounds maybe a little sad, but it's part of life when, taking care of them from birth through their lives, but also when they develop really serious healthcare conditions and even dying, and being with them through the death and then grieving process with the family. So that's been extremely rewarding. But then the other component, which I think is important, is to have an impact in the community. So I think taking care of individuals and individual families is extremely important, and I love that. But I think if it needs to be coupled with making an impact in the community. And so working with organizations like our state medical society, with the church organization that I work with Catholic Charities, with an organization called the Coalition to End the New Jim Crow, to work with organizations that improve things on a community level, which, by the way, you've said how you really enjoy working with me. I really enjoy working with you, because I think that's what you're doing through TOVA, is working with individual patients, but also working on a community level to improve care for sickle cell and other chronic diseases from a community level. And I think you have to take both approaches, because if you only take care of individual patients, then you never see the people, you never fix the problems in the community, and you might not even see the people in the community who don't come to a healthcare provider.
Right.
So I think doing things at both levels, I think we have a lot further to go. on a community level, I think you can always do things as an individual healthcare provider. It's much harder to improve things on a community and a societal level. So I really appreciate the work you've done, and to really provide an example for other people to work both with individual patients, but also with the community. I think we need to do both.
Yes, and I don't think I mentioned that, Dr. Gill, you are our medical director, and it's been a great pleasure working with you, and the patients definitely appreciate having you on board, and that I would say that in your practice, everybody gets access to high quality of care, and we really try to set the bar high for everyone. So I greatly appreciate all of you've done and your service to the community as well. So I want to thank you so much for coming on Your Health Matters today. I've learned so much, and I'm so grateful for the work that you have done in the community. And I would say that we need more doctors like you to step into your role. And I hope that we can get more primary care providers and residents that want to go into primary care, because that's where the care should start, not with the specialist. So I want to thank you so much. Do you have any last minute comments?
Yeah, no, I completely agree with you. I'd love to see the day when physicians coming out of medical school and nurse practitioners coming out of nurse practitioner training, that most of them want to go into primary care because of their passion, but I would love it for them not to have to choose not to go into primary care because they can't afford it. So that's what I would love to see. So I think if we continue to move in this direction, I think hopefully we'll get there, like is already true in most other countries. I hope that becomes true in the US and in Delaware as well. So yeah, I really appreciate your time. It's been great spending time with you, and I always love working with you too.